Assalamu alaikum. Now it's the time of diabetes. It's the time of diabetes. The endocrinology part of the USMLE inner circle. Start with this. Subtypes of diabetes mellitus type 1, type 2, and Modi. Modi, not the Indian president. Sorry, Indian Prime Minister. It's monogenic diabetes. Type 1. Type 1 is absent insulin. That means absolute insulin deficiency. In type 1, there is absent or absolute insulin deficiency. In type 2, there is relative insulin deficiency and insulin resistance. And in monogenic diabetes, there is impaired insulin secretion and impaired glucose sensing. Impaired insulin secretion and impaired glucose sensing. In type 1, associated features usually young, normal weight and family history, and in type 2 it is less frequently adolescent and overweight and family history. This is high. Type 2 has family history is common, and in monogenic diabetes usually age less than 30, normal weight and family history is common. It is autosomal dominant inheritance. So type 2 has family history. Type Modi has family history. Modi has normal weight but type 2 for obese. Ketoacidosis present for type 1, acute, severe polyuria, weight loss. Ketoacidosis present in type 1. In type 2, ketoacidosis is rare, it is gradual and asymptomatic. And Modi, mild hyperglycemia and ketoacidosis. If you do lab, undetectable C-peptide, positive pancreatic autoantibodies, undetected C-peptide and positive pancreatic autoantibodies. In type 2, there is elevated C-peptide, pancreatic autoantibody is absent. Elevated C-peptide and pancreatic autoantibody is absent. In MODI, monogenic diabetes, in monogenic diabetes, detectable C-peptide and pancreatic autoantibody usually absent. Okay, glycosuria is not sufficient to establish the diagnosis of the diabetes mellitus. So glycosuria is not sufficient to establish the diagnosis of the DM. Clinical features of the autonomic neuropathy. It may be tachycardia, impaired exercise tolerance, postural hypertension with loss of diurnal pressure variation, peripheral nerves, dry skin, pruritus, callus formation. There may be foot ulcer, poor wound healing, charcot arthropathy. There may be gastroparesis with delayed gastric sensing, esophageal dysmotility with possible dyspnea, intestinal involvement with possible diarrhea, constipation, and fecal incontinence, and genitourinary. There may be erectile dysfunction, retrograde ejaculation, decreased libido, dyspareunia in women, and decreased ability to sense full bladder, leading to incomplete emptying and decreased urination. What is the likely diagnosis of an insulin-dependent diabetes patient with anorexia, nausea, vomiting, early satiety, and postprandial hypoglycemia? The postprandial hypoglycemia without heartburn or epigastric burn. This is diabetic gastroparesis. So anorexia, nausea, vomiting, early satiety, and postprandial hypoglycemia. Think about diabetic gastroparesis. Hypoglycemia episodes due to insulin administration prior to meals, followed by impaired gastric emptying, followed by impaired gastric emptying and delayed absorption. Monofilament testing is necessary. Monofilament testing is necessary to Determining the presence of autonomic peripheral neuropathy. Tests pressure sensation with a 10 milligram monofilament. Patients with neuropathy have a high pressure threshold and low and loss of monofilament sensation, which are associated risk of loss of monofilament sensation, which are associated risk of increased foot ulceration. Check You have to check with this monofilament test annually. The tuning fork test is easy and inexpensive to assess the loss of vibratory sense in patients with diabetic neuropathy. The tuning fork test is seen in patients with diabetic to assess the diabetic neuropathy. Insulin resistance is the fundamental response to injury or stress is a well-known phenomenon for post-op or post and post-trauma patient. And key idea: if a patient develops diabetes, do not assume that they have type 1, because a lot of children, especially now with high rates of obesity, type 2 are increased risks of developing type 2. Okay. Indication for testing: if the patient is more than 35 years age, if the patient is less than 35 year age with both like overweight and or obesity, and one of the additional risk factor for type 2 diabetes mellitus like HIV, cystic fibrosis, and post organ transplantation. Consider in women who are planning pregnancy with any risk for type 2 diabetes mellitus, obesity, and overweight. If tests are normal, repeat in asymptomatic patient at least every 3 years, and patients with pre-diabetes should be tested uh, at least annually to detect a progression. What are the tests we should do? HbA1c. Um, HbA1c more than 6.5% is diabetes, 5.7 to 6.4 increased risk, and less than 5.7 is normal. Fasting blood glucose more than 126 is diabetes, and less than 100 is normal. Random to more than 200 is diabetes, or 140 over 199 increased risk, and less than 140 is normal. And OGTT, most sensitive test, most sensitive more than 75 gram glucose load, more than 200 milligram per dl is diabetes, and less than 140 is normal. Okay, this is very high yield. What should be our glycemic control target? If it is less than 7 in younger and otherwise healthy patient, younger and otherwise healthy patient, and less than or equal 8 in older patient. Nephropathy screening, annual random urine albumin creatinine ratio, annual urine albumin creatinine ratio. If it is less than 30 milligram per gram, it is normal. Periodic serum creatinine level, retinopathy, dilated eye examination every 1 to 2 year. Uh, this is neuropathy. This is retinopathy. Now neuropathy, visual inspection at each visit, and annual comprehensive foot examination, and cardiovascular risk reduction, annual lipid and BP screening, and aspirin and statin. Okay, what test should be screened for diabetes patient in polycystic ovarian? In diabetes, in PCO, OGTT is more sensitive than fasting blood glucose and HbA1c with PCOS. Now, the very high yield diabetic ketoacidosis, it should be in a young brittle type 1 diabetes, maybe initial manifestation of diabetes. Initial polyuria, polydipsia, blood vision, weight loss, and later hyperventilation and abdominal pain, Increased glucose, typically 300 to 800 milligram per day. Metabolic acidosis, bicarbonate less than 18. Bicarbonate less than 18 milliequivalent per liter. An increase in ion gap and positive serum ketone. Diagnosis: if glucose is more than 300 to 800 milliosmol per milligram per day, if there is metabolic acidosis, a high anionic metabolic acidosis, bicarbonate less than 18. So glucose 300 to 800, bicarbonate less than 18, increase anion gap. There is hagma, high anion gap metabolic and positive ketone. High blood flow, IV insulin and replace potassium. These are the managements of decay: initial IV isotonic fluid and then subsequent continuous isotonic fluid. If serum sodium continuous, if serum sodium is less than 135, switch to half strength normal saline. If serum sodium is more than 135, add dextrose when serum glucose is less than 200. Add dextrose when serum glucose is less than 200. Insulin, reduce insulin infusion rate. Reduce insulin infusion rate when serum glucose is less than 200. Reduce insulin infusion rate when serum glucose is less than 200. Hold insulin infusion if serum potassium is less than 3.3, and switch to subcutaneous insulin or decay resolution. Switch to subcutaneous insulin on decay resolution. Potassium, give replacement when potassium is less than 5.3, and bicarbonate, consider replacement for decay with blood pH is less than 6.9. Normalization of the anion gap and patient able to eat. Because there is a delay in the absorption of insulin when it is given subcutaneous, the insulin infusion continued for 1 to 2 hours after administration. Uh, After administration of subcutaneous insulin, this bridging process ensured the sufficient time for subcutaneous insulin to take and prevent the rebound ketoacidosis. In contrast, to diabetic ketoacidosis, which typically rapidly over hours, HHH develops few days to weeks. In decay, which is develops rapidly over hours, HHH develops days to weeks. How do you use nitroprusside or direct assay beta hydroxybutyrate? Nitroprusside or direct acid beta hydroxybutyrate to monitor resolution of the decay. Direct assay beta hydroxybutyrate nitroprusside picks up the acetoacetate and acetone only. Urine dipstick does not pick up beta hydroxybutyrate and can be used if ketone are negative but still suspicion for decay. Ketone is negative but you are suspecting Mm, decay, then you should do direct acid beta hydroxybutyrate. Direct acid beta hydroxybutyrate in here nitroprusside picks up only acid acetate and acetone only, not the beta hydroxybutyrate. What else can be used to monitor decay? Serum and gap to monitor DKA. What is the most important initial step in the management of a patient with hyperosmolar hyperglycemic state? Fluid replacement with normal saline. May switch to 0.545% saline after a few hours if corrected sodium levels are high. If corrected sodium levels are high, if IV insulin with or without potassium are important, but not important initially. Uh, Diabetic ketoacidosis in children, polyuria, polydipsia, vomiting, polyuria, polydipsia, polyphagia, vomiting, abdominal pain, weight loss, Kussmaul respiration, dehydration. In here, lab glucose more than 200, bicarbonate less than 15, but for adult it is less than 18, pH is low 7.3, anion gap is more than 14, and presence of serum or urine ketone. Management is 10 ml per kg isotonic fluid bolus, 10 ml per kg isotonic fluid bolus over an hour. Insulin infusion plus isotonic fluid with potassium and cerebral edema. Treatment progressive therapeutic intensification in type 2 diabetes mellitus. Metformin preferred, metformin plus oral antidiabetic GLP-1 basal insulin, then basal bolus insulin, then basal bolus insulin. What type of insulin therapy is indicated in type 2 diabetes mellitus with persistently elevated HbA1c level despite oral antidiabetic regimen like failed dual therapy? Basal supported oral therapy, long-acting insulin like insulin glargine, lantus before bedtime combined with oral antidiabetic drug. So, what type of insulin therapy we should use? Basal supported oral therapy, long-acting insulin, insulin glargine before bedtime, combined with oral. Which step? Which is the next step in the management of diabetic patient taking metformin and lightly insulin glargine that presents with elevated HbA1c, then and normal fasting glucose, and despite normal fasting glucose is normal but HbA1c is elevated, then add rapid acting mealtime insulin. Then we have to add rapid acting mealtime insulin. First, in oral therapy, if we are unable to control after oral therapy, then add insulin glargine. These is long acting insulin at the bedtime. If it does not cover, then add rapid acting mealtime insulin. This patient has likely postprandial hyperglycemia, and patients with elevated HbA1c despite normal control of fasting glucose and may have postprandial hyperglycemia. A combined regimen of long-acting glargine to control the baseline of the fasting glucose and rapid-acting mealtime to control the postprandial glucose excursion may be needed to provide optimal control. The indication of the insulin therapy in diabetes is newly diagnosed with HbA1c more than 8.5 and symptomatic diabetes, pre-gestational and gestational diabetes, and end-stage renal failure. Also, if the patient is insufficient glycemic control target A1C not reached over the 3 months of the period with metformin and other anti-diabetic drug, initiate basal insulin. So if target HbA1c is not met, then we have to add basal insulin. If the basal insulin like glargine, if that cannot cover, even if you add this glargine, HbA1c is not in the control level, then you should add mealtime insulin. Okay, oral anti-diabetic agents are contraindicated in renal failure, should also be avoided in patients with surgery or severe illness. What should be used instead? Insulin therapy. Recommended for therapy in addition to metformin, which remains the first line agent for type 2 diabetes mellitus. Okay, SGLT2 inhibitor and glucagon-like. SGLT canagliflozin empagliflozin can increase urinary glucose excretion. It can cause weight loss. Biguanide, GLP-1 receptor agonist, and SGLT. These are the drugs used in weight loss. They can decrease the cardiovascular disease and heart failure related mortalities. Thus, they slow the progression of the albuminuria. They slow the progression of albuminuria in diabetic nephropathy. And GLP-1 receptor agonist semaglutide, liraglutide, uh, of these use weight loss and reduce mortality in atherosclerotic cardiovascular disease. In atherosclerotic cardiovascular disease, so cardioprotective anti-diabetic are GLP-1 and SGLT2, GLP-1 and 2, GLP-1 and SGLT2, lipid, anti-lipid, statin, low-dose aspirin, blood control less than 130 over 40 over 80 by 90, an AC inhibitor is preferred, and a smoking cessation this and that should be done. This is very high SGLT2 inhibitor, canagliflozin, dapagliflozin, empagliflozin increase urinary glucose excretion, block proximal tubule. It blocks proximal tubule glucose reabsorption. It reduced progression of nephropathy and albuminuria. It reduced cardiovascular morbidity and mortality. Reduced hospitalization for heart failure and weight loss. Euglycemic ketoacidosis, increased risk of genitourinary infection. Contraindication type 1, history of DK. Type 1 history of DK and impaired renal function. Type 1 history of DK and impaired renal function. Mm, Morning glucose is dependent on how much long-acting insulin you give at night. Give basal bolus a regimen, giving basal insulin 1 to 2 times daily and bolus 30 to 40 minutes before the meal. Bolus injection needs to be adjusted to preprandial glucose measurement. 1 unit of insulin lowers 30 to 40 milligram per deciliter. Glucose lowers 30 to 40 milligram of what drugs continued in acutely in with sepsis, acute renal failure, low dose for taking patient low dose aspirin, atorvastatin, metformin, sitagliptin. Metformin contraindicated in congestive heart failure, CKD, and liver disease. Risk of increased lactic acid due to less metformin excretion. Recommended. Not recommended if creatinine is more than 1.4. Creatinine if creatinine is more than 1.4. And nephrotoxins such as NSAIDs and metformin should not be given to patients with acute renal failure and sepsis. Low-dose aspirin has not been shown to precipitate or worsen renal failure. How should patients with type 1 diabetes mellitus with their insulin when exercising? Exercise increase insulin sensitivity and decrease insulin doses 1 to 2 units per 20 to 30 minutes of so if you walks for 20 minutes, then 2 units of insulin should be 2 units less insulin should be given to the patient. Monitor glucose before and during exercise. Eat less absorbed carb after exercise and to prevent hypoglycemia. For brief exercise less than 60 minutes, patients occurring within 3 hours after meal, shortening insulin given prior to meal and should be reduced. In addition, the patient should have slow releasing carbohydrate snack following exercise to prevent hypoglycemia 4 to 8 hours after exercise. For exercise that patient occurs before breakfast, fasting rate lasts throughout the day, camp tournament and basal insulin in addition to uh, appropriate pre-meal insulin dose. Okay, this is the way of determining how we can give insulin. Not that important. Okay, DKD. Okay, the diabetes complication like diabetes, nephropathy, neuropathy will be discussed in a separate video along with this management. Okay, we'll see next.